The other central tenet that I'll say is that you want to make sure that you don't chase perfection. And if you have mild PVLs, you don't go chasing it down and aggressively post-dilate, especially in patients with annular calcium, because you may never expand against that calcified raphe because that is like hard as a rock.
Welcome to this episode of CardioNerds CathMasters. Today, we will be discussing the TAVR case in a bicuspid aortic valve. I am Nazli Okumus, an interventional cardiologist at CVI Central Florida, and I have had the privilege of serving as chair for the CardioNerds Interventional Cardiology Council. We have an excellent panel of discussants joining us. I will be presenting the case and pausing along the way to get their perspectives on key decision points and management strategies. I'm looking forward to the discussion. I will let our panelists introduce themselves as we get started.
Hello, everyone. I'm Niko Spilias. I'm an assistant professor of medicine and interventional structural cardiologist at the University of Miami. I look forward to this discussion today.
Hey, everybody. I'm Grant Reed. I'm an interventional cardiologist at the Cleveland Clinic. I am the Interventional Cardiology Fellowship Program Director. I hold the Basler Family Endowed Chair in Interventional Cardiology, and I'm an Associate Professor of Medicine at Case Western Reserve.
Hey everyone, this is Amit Goyal, co-founder of CardioNerds, and man, I am so excited for this episode, one of our initial AngioClub formats for CathMasters. What a joy to be here with this crew, Nazli as the chair for our IC Council, Niko, who was my co-fellow. We saw it through thick and thin together in the trenches in fellowship. Niko, so great to be here with you on this. And Grant Reed, together with Niko, we had the privilege of being Grant's initial batch of interventional cardiology fellowship graduates once he took over as program director. Grant, it was such an honor to learn from you as part of our training and hoping to show some of that magic here to our audience.
Thanks a lot, Amit. It's really my pleasure and privilege to be here. Kind of come full circle, having been a part of your training, which I'm very proud of participating here. It's really a joy. So thanks for having me.
Thank you so much, Grant. Nazli, let's talk about your case.
Thanks, Amit. Let's start discussing the case. I'm really excited to hear how you would all approach this case. We have a 71-year-old male. He presents to the clinic as hospital follow-up after an acute decompensated heart failure presentation. And now he's describing us NHA class 3 heart failure symptoms. During hospitalization, an echo was performed that showed LVEF of 30 to 35%. And severe aortic stenosis with a mean gradient of 42 millimeter mercury and AVA of 0.4. His EKG showed QRS length of 128 milliseconds and no evidence of first degree or right bundle branch block. A coronary angiogram was performed that showed mild CAD. He is low risk for surgery with a STS score of 1.6%. However, due to his severe mobility limitations, especially the knee problems, he has difficulty with mobility, and he was deemed a high risk for surgery. A CTA TAVR was performed, which showed ascending aorta diameter of 4, and his aortic valve calcium score was over 10,000. There was left internal carotid artery stenosis that was reported as more than 70%. However, his bilateral femoral access sites were deemed adequate for transfemoral access. CTA TAVR showed type 1A bicuspid aortic valve with an annular area of 618 millimeter. And you can see these images on our website as well. LVOT area was 617, and ICD 4 millimeter above annulus was measured as 30 millimeters. STJ was more than 32 millimeters, so pretty generous, and height of STJ was 25 millimeter. And sinus of Valsalva diameter, again, was pretty generous, 37 millimeter, 39, and 40 millimeters. Coronary heights were adequate with RCA height of 19 millimeter and left main height of 15 millimeters. So based on what we have so far, what would be your approach in terms of recommending this patient TAVR versus surgical aortic valve replacement?
This is a case that we encounter not very, very often, I have to say, but TAVR in bicuspid aortic stenosis It's becoming more and more common as TAVR expands in younger, low-risk populations. This patient, although is considered like low surgical risk per the conventional STS score, he has severe mobility limitations, it seems like. And then he has a low ejection fraction, which appears to be non-ischemic cardiomyopathy, most likely related to the severe aortic stenosis. And more importantly, he had a heart failure hospitalization, recent heart failure hospitalization, which can be classified according to the new term, the recently introduced term of acute valve syndrome. So this patient was hospitalized, the setting of severe aortic stenosis with heart failure. So this is not entirely captured in the traditional risk scores or STS scores, and this patient is certainly high risk for surgery, and also there is concern for his rehabilitation after surgery given the mobility limitations. So I would say that the initial thought on this case is TAVR. Of course, we have to take into account the anatomy based on the CT scan. It's not a very favorable anatomy for TAVR. It's a bicuspid aortic valve, severely calcified, calcium score over 10,000. And this is certainly a consideration in this case. But overall, looking at the big picture, I think TAVR is probably reasonable in this case. So I would be very interested in hearing the rest of the panel thoughts on that.
Yes, Niko, I completely agree with you. I think especially as we offer TAVR to increasingly younger and lower risk patients, we are more likely to come across bicuspid aortic valves, and we see that in practice. And while surgery is still felt to be first-line therapy in these patients, the gap between TAVR and SAVR is narrowing with improved techniques, better sizing, and improved valve iterations. I think in general, I would strongly favor surgery for patients who are truly younger, particularly less than 75 years old. In the absence of aortopathy, which comes together with a bicuspid aortic valve often, and this patient's aorta does not meet that requirement, and particularly for patients with very hostile anatomies, thinking about exuberant calcification in the annulus and LVOT, which this patient doesn't seem to have based on the CT descriptions. This patient, like Niko, you outlined, the STS score probably underclassifies his surgical risk with his mobility limitation, which will limit his post-op recovery. And this is certainly a more urgent evaluation in somebody who was recently admitted with heart failure. So I think in this patient in particular, without hostile anatomy, who's young, but overall probably high risk for surgery, I would probably favor TAVR in this setting. And that's also counterbalanced with procedural risk for TAVR itself, which we'll get into. But I'd love to learn from you, Grant. How do you approach in general, and maybe for this patient, TAVR versus SAVR in patients with bicuspid aortic stenosis?
Good. Well, I'm glad that I trained you guys well, because those are a lot of the points that I would make. One key point that I think we should all appreciate as interventionalists and as cardiologists in general is that when we think about the lifetime management of a patient with aortic valve disease, we should be thinking about a strategy in which we can minimize the number of sternotomies in the patient's life. And if they do need surgery, which many patients with bicuspid aortic valve disease do, it's performing surgery at an age that the surgery will be the lowest risk possible. And in some patients that may have, for instance, radiation heart disease or a compelling reason to avoid surgery at a young age, TAVR as a first strategy may make sense. But they should always be approached from the mindset of how do we best strategize for not just now, but 5 and 10 years and even 20 years down the road. And with bicuspid aortic valve, the majority of bicuspid valve TAVR, I think the vast majority that I'm doing, are in patients who are actually high surgical risk, who are patients who have bicuspid anatomy, which either are younger and, as in this patient, have reduced ejection fraction or end-stage renal disease or some compelling reason to avoid surgery, but yet have bicuspid anatomy. And it's those patients who are truly young with bicuspid valve disease that actually are a minority of the bicuspid valves that we're treating, because those patients generally are better suited with surgery, understanding that tricuspid valve aortic stenosis is really all that's been studied in randomized clinical trials. we have a prospective cohort of the Partner 3 trial, of which patients with bicuspid valves did as well as patients who underwent surgery out to 1 year. But importantly, that's not truly randomized data. And in the STS-TBT registry, we have data and outcomes which are longer term, but they do suggest a slightly higher risk of complications than compared to patients who have tricuspid aortic valves. So we generally, we don't want to subject our patients to more risk than they need to take. And understanding that surgery is an excellent treatment for patients at a young age, it tends to be what we offer first. But in a patient here who's 71, although the STS score is low at 1%, it obviously does not tell the whole picture. This is why the STS score, though it's a great tool for us, it's not the only tool that we have. And that patient that may be severely frail or have mobility limitations, have an EF reduction, I think that TAVR is a very good option, even if they are technically younger, because this patient's life expectancy may otherwise be less than 10 years.
These are excellent points. And interestingly, the day that we discussed this patient at our heart team meeting, we had a very similar bicuspid aortic valve presentation. Same age, very similar STS score, which was again low, and even the CT looked pretty much the same, which was very interesting. For that patient, because he was going to be able to tolerate rehab and be more functional, we decided to go for surgery after having a very similar discussion. And for this patient, the decision was made to proceed with TAVR. So let's talk about risks in bicuspid TAVR. Based on these CT findings, what are the anatomical risks in this case? Niko, what are your thoughts?
Yeah, of course, looking at the anatomical details of this case, we have a severely calcified type 1 bicuspid aortic valve. The raphe, it's calcified, doesn't look like a very calcified raphe, but it's calcified. So always with a bicuspid valve, we know that the risk for complications during TAVR, the risk is higher. I mean, that includes annular rupture from the severe calcification. It includes paravalvular leak. And also we need to take into account the elliptical annulus and the asymmetry of the sinuses that I would say the main risks here are a paravalvular leak. So the valve needs to be very appropriately sized and oversized in this case. And at the same time, it shouldn't be too much oversized because of the severe calcifications. We should not risk the annular injury in this case. Other than that, from what I see, the access was adequate. So, and one final consideration for severely calcified bicuspid is the stroke risk, of course. So all these things we need to take into account and take all the appropriate measures we have to minimize those risks.
Yeah, I think that's exactly right. These are the things I worry about in patients with bicuspid aortic valve, a higher rate historically of paravalvular regurgitation, more so probably with self-expanding valves, but the rates overall have gone down with improved skirt around these valves. The higher risk for conduction system injury and needing a permanent pacemaker, particularly so with these Sievers type 1 valves with right-left cusp fusion, because that raphe will tend to push a valve towards the non-coronary cusp, just under which lies the conduction system, ripe for injury. Annular rupture and root injury, thankfully, we see extremely rarely, but did we happen, they're catastrophic. There is some data that when a patient with Sievers type 1 bicuspid has TAVR, the combination of a very calcified raphe and an excess leaflet calcification opposite to that, that combination at least tracks with a much higher mortality in the near and long term. This patient looks like excess leaflet calcification, but the raphe itself doesn't look super calcified. So although the overall calcium score of this valve is very high in the 10,000s, at least that morphology doesn't seem to be present in this situation. Stroke risk we'll talk more about, I'm sure. But yeah, I think overall, this anatomy seems favorable for TAVR with these caveats in mind.
Yeah, Amit, I think you said it well. There are certain characteristics which do increase the risk of PVL and other complications. And that's not just the valvular calcium, but also calcium that involves the annulus and into the LVOT. And this patient does not have that. 80% of all bicuspid valves are Sievers 1 with the right-left fusion. So this kind of falls into that category. And if you think about the kind of risk to a bicuspid valve, the simplest way that I'd put it is that the more tricuspid-like your valve is, likely the better outcome, the more predictable outcome you're going to have with TAVR. I'll say that across the board, I tend to have excellent outcomes for patients with bicuspid valves, especially those treated with balloon expandable TAVR. And it is across the board of different morphologies, but there's a few central tenets, which I'm sure we'll discuss, and that's making sure patients are adequately sized and not aggressively sizing. Generally speaking, I try to aim for about a 5 to 10% oversizing when I implant my valves. And for bicuspid valves, I may be on the lower end of that. So I'm maybe 0 to 5%. It doesn't mean that I'm using a smaller valve choice, but if I'm between valve sizes, I'm often picking the smaller one and I'm purposely not aggressively oversizing. In addition, is making sure that you adequately pre-dilate. And then after implantation, it's often post-dilating with at least the same delivery volume that you implant with, but also not being afraid to reach for a non-compliant balloon, like a true balloon afterwards, which may allow you to get better expansion. And then the other central tenet that I'll say is that you want to make sure that you don't chase perfection. And if you have mild PVLs, you don't go chasing it down and aggressively post-dilate, especially in patients with annular calcium, because you may never expand against that calcified raphe because that is like hard as a rock. And if anyone has ever seen surgery on these patients, like you're almost amazed that we even do TAVR in this. I mean, it's really an incredible, very stiff valve. Bicuspid valves are very, very challenging. You just even when you touch them out of the body. However, if there is mild PVL, you have to acknowledge that you may never make that better by pushing on it. You may actually cause harm to the patient if you do so. So accepting mild PVLs, being facile with catheter-based PVL closure, and just understanding that there are limitations to TAVR technology, I think is important because, in a high-risk patient, you may cure the aortic stenosis and save their life, and having a mild PVL afterwards, patients can live with and can do well. So I think the message here is that the perfection is the enemy of the good. And I think do your best, follow these general guidelines. And the number one is don't chase perfection.
Yeah, perfection is the enemy of the good. Well said, Grant. A question for you. The topic of pre-BAV. We will often pre-BAV bicuspid aortic valves, and I think of that as adding value in terms of modifying leaflets and potentially helping to split the raphe to some degree to help us advance our TAVR valve and improve expansion. Do you find that the pre-BAV has the same value, utility in Sievers 0 non-raphe type bicuspid valves?
Yeah. So the Sievers 0 valves, again, appreciating that it's a kind of a minority of the morphologies you're going to encounter, tend to do quite well with TAVR and are kind of its own category in my mind. As long as you have symmetric valve calcification, the Sievers 0 valve, they often behave very much like a tricuspid valve. What's probably the most challenging part of a Sievers 0 valve is that there really isn't a cusp overlap view. There is not a coplanar angle. What I recommend doing is taking a careful aortography ahead of time and just making sure that you know exactly where you want to implant that valve because there could be different orientations. The usual orientation is that you have kind of a medial and a lateral cusp. And in that case, a cusp overlap view may work, understanding that you just basically have two cusps. But what I find most challenging about the Sievers 0 valves are just that the angle of implantation can be slightly different than you expect. And the easiest are like the cases like this, where you have a right-left fusion, and then you can do a non-cusp isolation view or a cusp overlap view, and it's basically the same thing. I mean, you use the same angle, same technique that you usually implant with an REO caudal or a kind of more of a caudal angle if it's a horizontal aorta. But I generally still would recommend pre-dilating. And I think the rule I would more or less have is if the valve is heavily calcified, or if there is a calcified raphe, then the pre-dilation is really important. And the more that we do TAVR, the more we realize, and I think we're appreciating, that your initial implant technique and strategy and getting good expansion of your initial THV makes a huge difference in your risk for halt, your gradient, and ultimately your valve durability. I think this is probably very likely true and maybe part of the story of why we're seeing some of the evolutes, at least in the most recent data, have a higher rate of failure at 6 to 7 years, that the initial implant technique and getting good expansion is very important when it comes to not just short-term, but possibly even medium and long-term outcomes. So I would say that if you do not predilate, you almost certainly are going to want to post-dilate these bicuspid anatomies, unless it's just really a unique anatomy where there's not much calcium on it, you have good expansion. But the key is not setting a rule that you have to or not pre or post dilate. It's more just making sure that you get good expansion of that valve. And the strategy that is advocated most is an adequate predilation, whether you use a balloon or self-expanding valve, getting nice expansion of a properly sized valve, and then having a low threshold of post dilate, but more for valve expansion than it is to address paravalvular regurgitation, because there may always be a little bit, especially for a calcified LVOT, and you don't want to chase perfection and end up causing an annular rupture.
Yeah, that makes a lot of sense. Thank you.
Speaking of balloon predilation, for this case, how would you pick the size and type of your balloon?
Niko, what do you think? What would you choose in this case? And maybe you can bring up the LVOT measurements for us real quick too.
Yeah. Typically, especially for heavily calcified valves, I prefer to predilate, sizing the balloon based on the minimum diameter of the LVOT and annulus. Now, in this case, the annulus and the LVOT have about the same size, so it's more like a horizontal, like LVOT aortic root without any significant tapering. And I would also like to measure at the level of the raphe and the commissural level, which was measured around 30. Obviously, we're not going to use a 30 millimeter balloon here, but I want to get an idea also what the commissural distance is. But typically for these cases, trying to be a little bit on the more conservative side, I would size based on the minimum diameter of the annulus.
Amit, what's your strategy? And do you do minimum? Do you do average? How would you think about predilation in more bicuspid or just a heavily calcified valve in general? Because there's a lot of discussion about this and debate, and actually guidance has changed for self-expanding valves over the years.
Yeah, this is, I think, a great discussion. And I don't know that we know the right answer, but what is the purpose of predilation? One is to be able to cross your valve into the annulus. That's a pretty low bar, but sometimes that itself is a feat for some of these really tight aortic valves. But number two, Grant, as you so rightly discussed, is to ensure we get a circularized, well-expanded valve within the limits of what the calcium distribution is. So my typical rule of thumb here is to go with a minimum diameter of the annulus, but also be mindful of the intercommissural distance, the raphe length, and also the length, I call it anti-raphe length, essentially from the tip of the raphe to the opposite side of the sinus at that level, because I certainly don't want to oversize and tear the leaflets at that point. We also will see how our TAVR valve, whether balloon expandable or self-expanding valve, how it expands. If it's very eccentrically expanded, we also have the option, of course, of doing a post-dilation within some limits, so trying to mitigate the risk of injury. But Grant, what would be your guidance in this situation?
I think that's well said. It's changed over the years, where initially we were pre-dilating many of our balloon and almost all of our self-expanding valves and using the minimum diameter off the LVOT or the annulus. And it's since actually changed such that for self-expanding platforms, now it's being advocated to pre-dilate to the average diameter. So for bicuspid valves, I still tend to be conservative and I will do the minimum, but I also adjust for any annular calcium. So if there's a chunk of annular calcium and the average diameter would be like 24, the minimum would be maybe 22, but at the calcium, it's 20, I'll use a 20 balloon. And the idea is, again, that in not chasing perfection, that you want to try to improve your crossability of your TAVR valve, but then also get circularized expansion and understand you can always post-dilate. That's what I will generally do, is I'll usually pre-dilate off the minimum for a bicuspid, and then I will post-dilate one-to-one fashion to whatever I think the annular size might be if needed. But if it's a self-expanding valve, I may still follow the same guidance for using the average diameter, because that's what's been recommended, at least in Navitor and Evolute more recently. It's important to recognize that the balloon expandable valves just expand with so much more force. And the nitinol frame of the self-expanding platforms is by nature just, less radial force. It's a bit softer, and there's some advantages of that. but it's not going to expand nearly as well in a heavily calcified annulus, whereas a balloon expandable valve will. So you get away with maybe not pre-dilating as aggressively with the balloon expandable valve, whereas with a self-expanding valve, you really need to make sure that you're adequately prepped. And I would follow just whatever general rule that your usual plan would be for a self-expanding valve, understanding that you got to take into consideration all the things you mentioned with annular calcium and intercontrational distance and overall sinus dimensions.
Thank you for these excellent points. For this patient's measurements, the minimum diameter was 24 millimeter and average diameter was 28.5, and we ended up using a 24 true balloon. Are there any other procedural risks you would be worried about in this case?
Yeah, I think we talked about the full range of procedural risk, but I will say for this patient in particular, I would be concerned about needing a permanent pacemaker, already has a prolonged QRS and has like a RAFA at the right non-fusion, as well as embolic risk as well because of anticipating a pre-BAV as well as a TAVR valve deployment in addition to a bicuspid valve where there has been a signal for increased stroke risk as well as such a high valve calcium score.
One thing I'll add, and I think those are at front of mind, is the reduced ejection fraction, and you have around 30%. Most patients will tolerate rapid ventricular pacing for balloon expandable valve quite well. And, that said, it may be worth just checking the LVEDP ahead of time as when you cross the valve and trying to understand whether or not this patient's compensated or not. And especially if they're in a hospital in an active heart failure state, they may not tolerate rapid pacing quite as well. Those patients that don't tolerate rapid pacing, interestingly, patients that have bad LV dysfunction tend to do fairly well in my experience. It's those patients who have really bad RV dysfunction, severe PH, or maybe even cardiac amyloidosis that don't. So you just want to rule out those other issues as well. And because you don't want to double hit and end up trying your best to TAVR this patient and you have them get very sick on the table. Sometimes, and this has happened before, and maybe you guys have been in cases with me when this has happened where we've done the pre-BAV and the patients just really did not tolerate it well. They did not tolerate rapid pacing. And I think at that point you can consider escalating to support or maybe even say, all right, like maybe we should get this patient through their acute heart failure rather than do the TAVR. But there have been situations where the pre-BAV actually is quite elucidating and where you got to pump the brakes a little because the patient just really doesn't tolerate it very well. I'd say that's a minority of cases, but that would be something that would be hopefully not the case here, but at least something to think about.
Yeah, to your point exactly about how some patients with LV dysfunction, how well they do during TAVR, I've made an observation, I don't know if there's any data to support that, but I found that patients who have reduced LVEF and they still generate good gradients, like more than 40, and it's not like the typical low flow, low gradient severe AS. Those patients, I found that they tolerate even the pacing very well. What sometimes I have challenge with is patients who have truly like low flow, low gradient, severe AS. And those patients, I found that they tend to develop more hemodynamic instability after pacing and they need some more like pressure support during the procedure. I don't know if you all have made a similar observation.
Yeah, I think so entirely that these patients that have significant LV dysfunction, they do tend to do reasonably well after TAVR if they have an elevated gradient. And we still don't know why some patients recover their LV function and some don't. What we do know, just from all comers, is that about a third of patients with LV dysfunction will have some recovery in LV function after TAVR. And it tends to be more common in patients who have an elevated gradient because to be able to mount a mean gradient of 40 despite an EF of 30 to 35%, if that EF was normal and that gradient maybe 50, 60, 70 points. So it's more likely than not that the valve is the cause of the heart failure, or at least that there's some LV reserve. And again, this hasn't all played out in studies, but at least in my clinical practice, I've noticed that those patients that may have, an elevated gradient despite having a low EF, they actually tend to have LV recovery and at least have a better chance of that.
Yeah, exactly.
Given that this patient has a high calcium score and some carotid stenosis, more than 70%, what do you think about the stroke risk? Does he cross your threshold for cerebral protection?
That's a great question. So from mainly retrospective data, we know that TAVR in bicuspid aortic stenosis is associated with higher rates of stroke, although in the large randomized trials that included all types of aortic valves, tricuspid, bicuspid, those large randomized clinical trials did not show clear benefit of routine use of cerebral embolic protection. I think in this particular case, severely calcified bicuspid aortic valve, the presence of internal carotid stenosis, and the fact also that we're doing a TAVR in a younger patient, lower surgical risk, I would use cerebral embolic protection in this case. I'm trying to individualize the decision for every patient. Of course, we typically use cerebral embolic protection for valve in valve, TAVR, but for those like severely calcified bicuspids, especially younger patients, I tend to use cerebral embolic protection.
Yeah, this is a great question. And I think no one really knows the answer, right? Probably cerebral embolic protection for all comers seems to not offer benefit. The truth is probably in how do you personalize this approach and select for patients that may benefit. And I know there are efforts of developing AI modeling tools, looking at the CTA to improve the prediction of how and when to use cerebral embolic protection. Until then, we just have to use our gauges of which patients may be higher risk of embolic phenomenon during TAVR. And I think bicuspid aortic valves with a very high calcium score fits the bill for now without having more evidence and clarity. So in this case, I would use cerebral embolic protection, but Grant, what do you
Sure.
think?
No, I think that's well said. I won't expand on this too much more. We do it indiscriminately at the Cleveland Clinic, as you guys know, but you make your own decisions about that. And I think that, as you said, and Nico, I've been heavily calcified bicuspid valve. But if you are to use a selective strategy, this is a patient that I think would certainly fit the bill.
In a bicuspid case like this, how do you approach valve selection? What factors push you towards balloon expandable versus self-expanding or supraannular versus intraannular platforms? Amit, what are your thoughts?
Yeah, I struggle with this. The data is all over the place, and a lot of the comparative data between valve platforms is retrospective. And also with older generation valves, we have good evidence that with newer generation valves, complication rates have improved. I think in general, it's probably fair to say that balloon expandable valves are more likely to cause aortic root injury and annular rupture. Again, although the rates are very low, self-expanding valves, but for bicuspids and probably all comers, may increase the risk of conduction system injury, but that can be modified based on deployment techniques. I think for this particular case, you could probably go either way, but with having a prolonged QRS at baseline and a right left fusion, and not having hostile calcium, I'm worried about at the annulus, I would probably favor a balloon expandable valve. But I think this would be fair play for whichever valve platform the local practice has a preference for using.
These are great points, Amit. I found that with bicuspid aortic valves, that usually the balloon expandable valves have a little more predictable deployment depth. Particularly in this case, that the patient is 71 years old, I'm also already thinking about lifetime management and placing probably an intraannular balloon expandable valve that I can control the depth of deployments really well with our caudal or cusp overlap technique that we learn very well at the Cleveland Clinic. It gives me confidence that I'm going to get probably the best possible results. So I would probably prefer balloon expandable valve in this case for the reasons of lifetime management and need for valve-in-valve TAVR in the future, as well as a more predictable deployment depth.
Yeah, I wouldn't add much more to what you guys said. And, one other piece that was on my mind really thinking about this was that it is a fairly large annulus, right? You have 620 with the annular area. I'm not sure what the perimeter was exactly. It's, likely at the upper end of a self-expanding valve. So you would be looking at either using 34 Evolut or 35 Navitor. And when you are in the upper end of a range for the self-expanding, like you said, I think it sometimes deployment is a little bit more challenging. With that said, with all that calcification or restriction you're going to have at the valvular level, I have no doubt a self-expanding valve would probably seal quite well. And if there were annular calcium, that may be something which I would consider. But in this case, I think the features are relatively favorable for TAVR, and balloon expandable valve would be, I think, a little bit better in terms of lifetime management considerations. With that said, this SOV is capacious enough that I think even if you did use a 34 evolute, it would probably still allow you to do a tab and tab in the future. But the predictability is the piece. And I'm with you that I probably would pick a balloon expandable valve in this case for that reason.
How about the sizing of the valve? In bicuspid anatomy, how does your sizing approach evolve beyond just the annulus? What else are you taking into account?
Yeah, for bicuspid valves, the vast majority are still going to be determined by the virtual basal ring bound by the naders of the sinuses, but in a smaller proportion of patients, they may have greater restriction at the commissural level. So you shared with us the intercommissural distance was 30, whereas the predicted valve size based on the annulus or the VBR was 29. So this is a more typical sizing in this setting, but for the minority of patients where the root dimensions are narrower at the commissural level, I would downsize my valve accordingly, because there you would increase the risk for root injury and root rupture by sizing according to a larger annulus that would be too large for the root at the commissural level. Niko, do you have any other thoughts about how do you personalize sizing for the variations in bicuspid anatomies?
Yes, yeah, totally. Amit, I agree with you. We look, of course, at the annular area and perimeter first. Then I ask myself, okay, do we have a tapering anatomy, or do we have a more like uniform anatomy, comparing the LVEF, the annulus, and the area around the commissures, which is a few millimeters above the true annulus? If I don't see significant tapering, then I go by the annulus, and of course we're looking at the size of the sinus of Valsalva, and we would like to make sure that the valve size we choose is favorable for lifetime management as well. I agree with you. We have a tapering anatomy, one way or the other, we tend to be more conservative with the sizing. If the LVEF and the annular area and the commissural distance 3 to 4 millimeters above the annulus, all like match in size, then go by the annular area.
I think that you guys did a good job summarizing things. In borderline cases, it can get more nuanced. In this case, it's a pretty clear cut that this patient only needed 29 S3. One point I'll make is that in those centers that maybe you're choosing between using a Resilia model and not, for the 29, it actually makes a big difference, because 29s, that's either S3 without Ultra or S3 Ultra with Resilia. So in a case like this, where I was going to pick a balloon expanding valve, I would definitely use a 29 with Resilia, because if you don't, then you're basically using an S3, which is a couple models back, and the skirt is just very different. And it's deeper with the Resilia model, so you're less likely to have a miss at the annular level. So I always, at this point, I regardless of other factors, I will use all my 29s are Resilia now, because of some of the benefits of the valve, but also because of the skirt design. So there's a couple of points about that, but not much else I'd add to the sizing discussion.
This was such an amazing discussion and critical points about bicuspid valve. Thank you so much. And I will tell you what we did for this case. So as I mentioned before, we did proceed with TAVR, and we did use cerebral protection for this patient after discussing the points that you brought up already. And prior to valve deployment, we performed BAV using a 24 millimeter true balloon. After the BAV, which was tolerated by the patient very well, we used a 29 millimeter balloon expandable valve, which was successfully deployed. At the end of the procedure, patients did not need a pacemaker. Post-procedure, TT did not show any PVL, and next day echo showed LVEF of 40 to 45% with a mean gradient of 6 millimeter mercury, and still no evidence of PVL, and patient was discharged home next day. 1 month follow-up at the clinic, patient was doing fine, and echo showed LV ejection fraction of 55 to 60%, and main gradient across the aortic valve, TAVR valve, was 12 millimeter mercury with a DVI of 0.42. And we noted trace PVL on the echo.
Such a great feeling when you do TAVR and the EF normalizes. I mean, you basically have cured systolic heart failure. So this is what we were talking about earlier. That really incredible outcome. So congratulations.
Yeah, this is terrific. Nazli, congrats to you. And thankfully, this worked out really well for the patient. Doing great work just a year out of fellowship. Grant, Niko, thank you so much for joining us for this discussion, imparting your knowledge, your experience, kind of rekindling many memories from training. I can't wait to have you back at CardioNerds CathMasters. Thank you so much.
Well, guys, I'm very proud of you. I mean, you guys are doing fantastic work, and that Nazli as well. Wonderful job. It's wonderful to see you guys thriving. So congratulations, and just really gives me, just tremendous amount of joy. So keep it up. Keep up the good work.
Thank you. Thank you all for this excellent and very educational discussion.